Thank you, sir. Thank you for the opportunity. And I'll be giving a basic overview of the scleral fixated lenses and trying to share a few tips here. I think the scleral fixated IOL techniques can be divided into two major groups. The one where we suture the haptics and to the sclera. The haptics are fixed to sclera by using a suture. And the second would be a sutureless technique. In a suture technique, we were using 10-oprolin before. Now we've shifted to 9-oprolin, and then nowadays we use shifting to Gore-Tex. The sutureless techniques, which Dr. Nevian has shown multiple variations, and this is the modern way of managing this. The first introduction of the concept was by Dr. Gabor Shariat, where he created an intrascleral tunnel and the haptics were threaded into this tunnel, and that was what is fixating it. Then Dr. Amar Agarwal modified it, and the glued IOL came into existence. And the latest technique, which is very popular currently, is the Yamanese technique, wherein the haptic is cauterized to create a small bulb which goes and fixes into the sclera. And as we saw, Dr. Nevian, he has devised a new wonderful device, IOL, which is called as the T-Flex, where the T of the hydrophilic lens itself goes and holds or stabilizes the lens. So these are the common ways by which we use scleral fixated lenses, but there are certain complications which are often associated with these scleral fixated lenses. We have to understand them. Decentering and tilt is the more commoner complications which we get across. Of course, dislocation, especially when we are using 10-oprolin over a period of time, it just the lens just disappears into the vitreous cavity. Erosion of the sutures and haptics is a realistic complication, and it can cause infection, and that's what we are worried about. And vitreous hemorrhage and retinal detachment are the other complications which we need to be concerned about. Now moving on to the surgical technique, I'll be just sharing the classical sutured way of scleral fixated lenses, although we don't use it more often than nowadays, but this is what it is. Again, this is a case where a PMMA lens dislocated after many years of surgery. So it's about maybe about 10-15 years later. Now the patient is presented with a decentered lens, and I'm just going to go and take you through few basic steps here, okay? So these eyes will be very soft. So when before entering, you have to clear the scleral tunnel and the scleral flaps itself, because the eye would be very soft once you do that. So there's a reason why because it's a PMM lens, you have to have a 6.5 millimeter scleral tunnel to remove it, and then I'm creating those scleral flaps where we are going to bury tie the suture and bury under it. So that also is created before opening the eye. So that's what we are trying to do, because once the eye becomes soft, it becomes extremely difficult to maneuver. So I just going to forward it a little bit. You create the flaps as has been demonstrated by Dr. Nevian. Marking this horizontal meridian is very important. That helps us to ensure that we don't have a decentration or tilt to the lens. And once the flaps are made, then we are going to enter it. And under the cover of OVD, you push back the vitreous and pull out the lens inside. And this is the time you're going to create those paracentrous incisions. And one of the most important steps when you're trying to do the scleral fixated lens is, obviously here I'm doing in vitrectomy, is to fix the AC maintainer. We have to have some sort of a fluid which is going inside. Ideally, it had to be fixed before even starting the vitrectomy. That should be the best way to fix it. Because the fluid has to be going in. That's the secret of maintaining the chamber and preventing the eye from becoming extremely soft. And the double-ended Prolin suture is being used, and we are going to thread out the sutures both eyes outside, and then these sutures are going to be tied onto the hole which we have in the. These are conventional PMMA lens, which is slightly larger, which has got a hole in the aptic, and we are going to tie this suture on either end, and then it is going to be introduced inside. So this is how we are going to try both of the sutures. And nowadays we are shifted to using Gore-Tex. The only disadvantage is the cost of it, but it is definitely considered to be much more stable. And this is a critical step where you are going to ensure that the lens is reasonably centered. Both the sutures are externalize, and now we're going to use the same needle to suture it to the scleral bed so that it fixates well. So you're going to use 3-1-1 knots, which is then sutured on either side. And before tightening, we ensure that the lens is well centered so that the traction is equal on either side. Then you cut the knots in, and then the wound is closed. So until the last moment, you keep the AC maintainer, the fluid running inside. People who have done a pars plana vitrectomy, obviously they use a pars plana infusion source. For anti-segment surgeons like us, that is what we use. And that was it. The conjunctiva is closed. That's it. So it is a reasonable choice. The sutured scleral fixation is also a reasonable choice when you're faced with explanting a PMMA lens. So we are forced to make a bigger incision. Otherwise, you can always resort to the newer techniques where you can manage through a smaller incision like Yamane or CMT flex. So that was it. Thank you for the opportunity.